I know my clients. All right, so we're just gonna wait a few moments, everybody. Again, welcome to Sleep TV tonight. Just gonna let the room fill up a bit, and then we'll get started shortly. Let's take a peek here.
Live on Facebook, by the way.
Okay, perfect. Thank you. All right, this is awesome. Grab a pen. All right, awesome. This is good. We have a nice, good room here. Dr. Lynn, Dr. Levine. Okay, cool. Awesome. All right, we're going to give it like another little bit here and then we'll get started. Oh, Dr. Sadness is saying chat seems to be disabled. Can you take care of that, Faustina?
Literally just did it, so you guys are good to go.
There you go, Dr. Sadness. You're all set.
Did mine come through?
No, it didn't. You got to go like on the little pull down. You got to change it to everyone, not just hosts.
Well, yeah, it says, okay. I looked for everyone, but everyone wasn't a choice. Then now it is. Cool.
Yeah.
Dr. Hart. Yeah, a lot of familiar names here. This is awesome. Cool. All right, so it is 8:02 Eastern Standard Time, so we can go ahead and get started with this. So good evening, everyone. My name is Cindy with Sleep Group Solutions, and welcome to another episode of Sleep TV. We're very happy to have you all here join us this evening. This evening, I have the awesome Dr. Harrison, who's going to be coming over an awesome topic of decreasing titration appointments, and we're going to go over some highlights of the Eccovision. And I'm also joined this evening by Sleep Group Solutions President, Mr. John Nadeau as well. If anything, we are also live on Facebook, so those of you on Facebook, hello as well. If you have any questions throughout the webinar, you don't have to wait towards the end of the webinar. Start typing them up in the Q&A or the chat section. And for those of you on Facebook, put it in the comments. And when we get to tonight's, toward the end of tonight's webinar, we'll go ahead and review those questions. So Dr. Jeff, take it away.
And nothing's off limits too. So whether it's a discussion specific to what we talked about with, appliance titrations and Eccovision and trying to nail a more accurate bite right away, or it's anything related to dental sleep medicine that you think would be relevant to talk about, it's totally fine. We leave it as an open forum. Before I pass off to Jeff, I'd just say that, for me, this topic is huge because I spend my days, looking at the insurance side of things and big numbers as far as like group practices and huge high volume dental sleep offices, and everyone's looking at profitability. And I would love to snap my fingers and make insurances pay more for sleep appliances than they do, but that's not going to happen. What can happen is we can become more efficient. If you look at your overhead on a case, obviously your lab bill is a substantial chunk, but the next biggest piece to that is arguably the biggest piece even is your time. And when you fall into that hole of getting married to a case and you play that titration game, and the whole concept even of titration is kind of misplaced in dental sleep, really. That's where you get into some trouble, and that's where you end up investing more time and, of course, more money into chasing a solution that, if you did it correctly, you'd be able to figure out from the jump. So I'm excited to see what Jeff has to share tonight, and let's get things kicked off.
Yeah, I was thinking about the topic this afternoon, like, why is it important? So John nailed it on the head right there. It's all about chair time. It's about being efficient and not having to see the patient more times than necessary. So you minimize your chair time with that patient, which then results in an additional case that you can slide into the schedule because you've opened up time. I started to think back over my 30 years now of being a dentist and all the different techniques that I've invoked in trying to figure this out. And the first one that I tried made me just laugh this afternoon, because I was I was thinking about this one, and John, you've probably heard dentists talk about this, is the just take the impressions and send it to the lab method. So that was a titration visit number one. And, lo and behold, it worked sometimes. But it led to some TM problems. It led to a lot of advancement of patients. It led to actually losing a few patients because you get about 3 tries with them, and you're moving them forward, you're moving them backwards, and they just kind of lose faith in you. So that was one. So that led to the phonetic bite position, where we do the sibilant sounds, 55 to 66. But that was more for my headache type of patients, people that couldn't tolerate big vertical openings right out of the gate. So, there was that method. Then I had the George gauge method, like probably 90% of the dentists that are out there doing sleep medicine. Again, it worked sometimes. It wasn't until the Eccovision came along that I kind of saw the light. And for people that have heard the story, and John, I know you're familiar with it, but how I met John is he gave a lecture in a room right before I was going to give a lecture. And so, as a speaker, you always want to see, does the computer work? Does the projector work? Are the people in the room friendly? Who do you not want to make eye contact because it'll throw your whole talk off? And so I was just simply sitting in a room that John just happened to be giving a presentation on. And he had the Eccovision of the legacy version. This was like circa early 2000s. And I looked at it, I'm like, my practice has lasers, it has cone beams. I'm like, I don't really understand what it does. It's intriguing, but I'm not going to put that in my practice. My patients will think I went nuts. And if I had a time machine, I would go back to that day in history and I would pay John whatever he wanted for that piece of machinery. Because now that I know what I know and I see what it's capable of, it's a valuable asset. And it's not just for decreasing the titration appointments, it's getting case acceptance. It's getting the patient to understand that they have a problem. I mean, I dropped a lot of money on one of the very early cone beams in North America, simply for the fact that I was sold to it can measure airway. So I got the largest field of view back when large fields of views weren't cheap. And it was the best worst decision of my practicing days because yeah, I could find small airways, but I could find small airways just by looking in the back of the throat if that was my metric. What Eccovision does is it shows you the collapsibility. And so, fast forward through time, my timeline, I guess, if you wanted to back up that, is first I was going to surgically fix everybody. I was going to move jaws around, make perfect faces. Then I was going to slash tongues and teach them where to go. Then I was making oral appliances. I was doing ortho. So I came through sleep. I usually say backwards for most people. Most of our clients that sign up with Sleep Group Solutions are coming there specifically because they want to learn dental sleep medicine. So, that's the long story short version. As we jump in, let's see if Mike can advance my slides. Oh, it always does this when I open it before the thing goes live. Let me close it real quick. Now let's go back to share screen and see if I can advance slides now.
While you're playing, setting that up, I'll chime in on what you talked about, because you brought up a couple key things early on with the different techniques, and that for as long as I've been doing dental sleep has been my biggest pet peeve in all of sleep medicine. All these different techniques I see, whether it's George gauges or a dozen other gauges that all do the same thing, or different techniques, the phonetic bite or this or that, they're all what I'm going to call accidental bites. And by accidental, I mean, they all work, but not because they have anything to do with that specific person's airway, right? Accidental, like I could, whatever, I could take a stick of gum here and put it in my mouth and call it the gum bite, and it would work sometimes because it opens me up and brings me forward. Does that have anything to do with what my airway needs to be? Of course not. Just like a George gauge opens you and brings you forward. So there's a difference between kind of pulling you in a general direction and putting you where you need to be. Everybody has different airways. So there's a billion accidental bites out there that sort of just accidentally might work but they have nothing to do with what that person specifically needs. They just happen to bring you in the same direction that you might need to be. So it's absurd to me that the field has kind of stuck with some of that for so long. And I think, I mean, honestly, I kind of blame the labs and the appliance companies, and honestly, what's their interest in this is not to make taking a bite more accurate or more challenging. They don't care. They just want to make more appliances, and they don't want to put any roadblocks or technology or anything that could potentially limit the amount of people that are sending cases in. And so you see a lot of that being taught. And that's unfortunate, because what ends up happening is, like Jeff's going to talk about, you get a lot of people that are put into a position that's not ideal. You got to play these games and adjust and retest and adjust and retest, or you never find the ideal position, and somebody sits at home with an appliance with kind of subpar therapy, and that's also bad. So
And I think if we sat here and
it's-
talked, John, we could probably go through the whole slides without advancing one, because it's
okay,
what we
so you
do
wanna just
every
do that?
day.
That's fine. I'm
So
good.
it's
we
hard
can
not
go.
to get into this. But you've already alluded to this one, titration risks. This is a carryover from when CPAPs were titrated in the lab. Yeah, so we would go to the lab, put the patient on the CPAP, have them fall asleep, and watch their numbers and start adjusting the pressures on the patient until it reached a favorable outcome. And before I was into sleep, I thought of titration as like dosing a medication for sedation. So you titrate a little bit in, see what kind of results you get. If it's not quite there, you give a little bit more. So it means you guessed. It just means that you guessed wrong, and that you're going to guess again and again and again until maybe it works. And fortunately, half the time it does. But dentists are creatures of very unforgiving standards. And so half the time is not going to be what a dentist wants to see. They want to see it dialed in as fast as they can, as often as they can on every case. And in the real world, it's medicine. And if you improve that patient just a minimal amount, then that's considered a success. In dentistry, if you made their tooth just a little bit whiter, but it didn't meet patients' expectations, then it's a loss. So we have to look at this in the terms of medicine and not dentistry. We have to take off that dental hat and put on our physician's hat. So in dentistry, we are down to the microns almost in some things. If we used to guess with implants, we would just throw them in the jaw, we'd hit some structures, cause nerve damage, we'd go out the side of bone. Now we've got 3D planning, we've got cone beam. We can backwards work the case where we know what the occlusion setup is that we want, do the crown first, and then have the implant placed into the x-ray, and then make a guide. So it's almost like a monkey could do it, even though anything is never that simple. So why do we go about airway so haphazardly is kind of the question. We need to measure and treat it. In medicine, they do the same thing. They'll do a drug-induced endoscopy where they sedate the patient, invoke sleep, push a camera down the throat, start dialing up the pressures to see at what centimeters of water that airway stays open. And it's a law of diminishing returns. So if we look at these pictures, and I don't think I can move my cursor down there, but maybe I can. I don't know if you guys can see that. Here it's really collapsed. Here it gets a little bit bigger airway, a little bit bigger, a little bit bigger. And then it starts to look the same, right around 10 or 12 centimeters water. And so they're not going to dial this pressure up to 20, because that would be the patient having their head out the window going 100 miles an hour down the highway. If 10 is enough to keep it open to where they need, then that's how it needs to be. Fortunately, the technology has improved over the years. They've got auto PAPs out there. We have BiPAPs out there. The fans have gotten quieter. They got humidifiers in them. The downside to it is it needs maintenance and upkeep, and there's disposables. And if the patient is not compliant with it, the insurance stops paying for that. Also, when a physician can't give them an alternative, oftentimes they don't talk about oral appliances as an alternative. Fortunately, I see the needle moving. And for a long time in my career, I did not see that happening. But I would say in the last couple of years, there's more and more research and evidence and more practitioners that are doing sleep at a high level, that it's starting to get the attention of the physicians. And so that's my advice to anyone that's on this, that is guessing currently is schedule a time for myself or one of my colleagues at Sleep Group to come in and spend some time in your practice. I know in a couple of weeks I'm going to go down, actually it's next week, I'm going down to visit with a doctor who's been dabbling in sleep for about a year. He's a diplomat. He's not quite getting the case results that he expected or he wanted. So I'm going to go in and spend a day in his practice. We're going to look at cases that he's been struggling with. And he doesn't have our technology right now. So that'll be interesting to see, what do we find out with that in the place that maybe could have saved him time and some frustrations. So that's what I enjoy doing. I don't know, I guess a natural born teacher. That's why I took this position for Sleep Group. Is I could sit in my practice and see one patient after the next, but that's just like sitting next to a quiet, still lake and throwing one pebble into the pond at a time. When I can go address a large audience or a room full of people and they take action, go back to their practice and decide to employ these systems and protocols that we've developed at Sleep Group Solutions, then I'm chucking that whole hand of rocks into the lake. And I believe that's why I'm here to make my impact on the profession before my days are done. So I got to move my camera so I can see what we're talking about here. The goal with oral appliance therapy is it to slowly advance the jaw until you've reached maximum protrusion? I was taught that at one time. I never invoked it, thankfully, because side effects started to happen. As you move past the tolerance of that patient, then all kinds of things can go sideways. You can recapture missed or lost disc. I had that happen twice in my career. And really what it was is I just didn't ask the right questions on the front end. I asked the patient if they had jaw clicks and pops, and they said no. Then later on, as we advanced, they popped back onto their disc. And now in the morning when they went to take their sleep device out, their bite was changed. Patients typically don't notice this, but their dentist, if it was referred to myself as, a sleep specialist, if you want to call it that, the dentist would call you up and say, what happened here? And it's actually probably a good thing. If they were off the disc and back on it, would you rather have a joint that's slowly degenerating over time, or would you rather have someone that's back onto their disc and now you can rehabilitate them into that position with orthodontics or restorative, whatever we need to do. For many years, I used this, let's make the device, let's titrate it, ask the patient how they're feeling. If they feel like they're subjectively improving, then we'll retest them, get the objective measurements. If it's not quite there, we would titrate them further forward again, let them go for another month or two, ask how things are feeling. If things seem like they're going better subjectively, retest again. So we have the objective measurement. And eventually what happens is, if you're right, you're fine. If you're wrong, your patient gets really upset and thinks you're messing with my health by guessing. And now my jaw hurts. Now my bite's changed. Now I got spaces between my teeth. We've all heard all these things. And so I think of some of my earliest cases, which were mainly snoring devices. And I would make a popular snoring device by a large lab out of California. We won't say brand names there. And then they would break. And I used to get really upset. Oh, it's broke. So I remember this one patient. He just wanted a device. He says, the only reason my wife will stay married to me is if I wear that device. And so I wear it every night. I've had 5 of these, I've broke them all. Is there anything else that we can do that's stronger? So I just happened to make him a lab fabricated device for obstructive sleep apnea. I never had a diagnosis. I mean, we were cowboys back then. We were shooting for the hips and just trying to help the patient and do the best we could. Would I change things today? For sure. But that's the story of the history and what happened. And I can't go back in a time machine and change it. But I can teach a better way to do it so you don't have to repeat the same mistakes. I think that's probably one of the biggest selling points that I will make in a talk to someone is I've been doing this a long time and I've made a lot of the mistakes that can be made. And so my goal, if you're not into this and you're considering getting into it, partnering with us will give you that advantage. It gives you that leg up, that friend in the business that has worked with a lot of different practices and made a lot of the mistakes, so you don't have to make them, and you don't have to suffer through. Your patients don't have to suffer through, and you will get to the top, hopefully, much faster than anyone else has ever been able to reach the top in dental sleep medicine. So that's what we're excited about. But if we think about, how many times you're going to retest this patient, there's a cost involved with that. So that usually is the next topic that comes up, is do you bill for those follow-up tests? And typically on my cases is I would include, they would do the diagnostic test, and then I would include my efficacy test in my case fee. But when you start doing that multiple times, unless you've built in multiple tests, it starts to impact your overhead and what you're spending on the case. And I think we would all agree that it's not a lot of fun to work and not make any money. I mean, it just doesn't make sense. That's when dentists just kind of throw in a towel and say, I'm done with this. I can make more money just doing implants, crowns, and bread and butter dentistry. So you need to know where you're going so you know when you get there that you've arrived. Now, my friend Jerry, who I have to give him credit for this one because he's the first one I heard describe it. Now, this may have come from John, but Jerry was the first one that I ever heard use this description. And he talks about his wife who likes shoes. Now, for me, I'm a male in the US and my shoe is 10 and a half. So I would be right on average. You could give me a 10 and a half all day long, and usually I'd be happy. Some shoes are cut smaller, some are bigger. But if they follow the standards of the industry, 10 and a half would be my shoe size. Now for females, it's 8 and a half. Now I know some ladies out there where their feet are smaller than that. And so that would be like Ronald McDonald's shoe on their foot. And I know some, their feet are larger than that. So it'd be like trying to get a really big object. Like I love this picture down here of the big feet with the baby shoes on the big toes. So if that's your shoe size, great. If it's not, then what's going to happen? Well, that's all I sell. So, I guess you'll get used to it, or don't wear it. Those are basically options. Or if it's titration, let's just move you forward a little bit. So we're going to go a half a size at a time because I can order them in, and we'll try it and see how it feels for you. And if it doesn't work, then we'll go another month and we'll go forward another 0.5 millimeter until we get you there. It just doesn't make sense. If there was a way to know from the outcome the first day that you deliver a device to the patient of where you're going, you can at least set the bar of expectations. Now, I see this often with new dentists in sleep medicine, is they use the Eccovision technology and they know what their vertical is and they know what their advancement needs to be to reach that ideal, 1 centimeter of improvement. And so they make their fabrication bite in that position, but it's beyond what the patient can tolerate. So you do need to look at the patient's habitual bite and where they're starting, look at where their therapeutic position is, and then make a judgment call as a clinician of how fast you can get there. Knowing the vertical is the first thing that we want to do in every case. When I teach how to use the jigs that we use that you're going to see in a minute, I do the same thing every time. So I use for normal occlusion. So let's call everybody class 1. Class 2s and 3s are the exceptions out there, but they're fewer and further between. For a class 1 occlusion, I would try a 6, an 8, and a 10 in an end-to-end or edge-to-edge type of position. Usually one of those 3 will pop out. Whatever one it is, if you've got the newest software, you'll see a star icon over those titration graphs. That's your biggest airway size overall volume. So go with that vertical and then bring them forward 2 millimeters beyond that end-to-end position and take one more measurement. So you're really taking a baseline, a collapse, and then 3 plus 1, so 4 titration positions. So you're going to have 5 collapse tests. Now, what I find is most patients can tolerate somewhere between 6 and 8 tests. If you used every jig in the kit, you'd be taking dozens of bites and tests, and you would fatigue your patient. The technology is extremely accurate, but there's 2 factors you have to think about. Number 1 is your technique, the words that you're using to instruct the patient to follow the method that you're trying to get them to do. So when I see erratic results, when I'm working with a client who's having issues of getting repeatability, it's typically one of those two things. They've got a technique that's not the same, and so they take a different measurement every time, or their patient isn't performing. The patient will blow off more one time, less the next time, and you will get erratic results. It's still accurate. It's accurate of what that patient did on that occasion. So you got to really dial in on what you're saying and what the patient's doing, and not fatigue them beyond the point of exhaustion to where they just can't perform for you anymore. So once we find where we're going, another great example, and John threw this in there, and I usually get the credit for it because I said, Eccovision's like GPS. When I was a kid, we would get around with a map and a marker. We'd mark on the map all the towns we went through. I think it kept myself and my two brothers out of my parents' hair as we drove around. But we would start to factor, how far is it to the next destination? But today I can land off a plane anywhere in the USA, type in the address of the office I'm going to, and I'll know before I even leave the parking lot from the airport when I'm going to arrive there. And if there's traffic, it'll divert me around. And to me, that is very similar to what Eccovision has the capacity to do for people. So, as we use the jigs, and I'm going to, let's see. For those that don't have it, Eccovision's the machine that we see in the distance here in that upper picture and lower picture. The top one is a pharyngometry reading where the patient is pinching their nose. And the joke I typically make is like a breathalyzer test. You're going to blow through the tube. So we're going to make people breathe through their mouth for this, which is what most people do when they fall asleep anyway, even though we know the nose is ideal. But that bottom picture is measuring the nose. So that's the rhinometry, which if you look back into the history of Eccovision, it started with rhinometry in otolaryngology. So ENTs were using this to measure distance and size, cross-sectional size of the nasal passages. A dentist had the idea, well, that would be great if I had one that went in the mouth, so I could test before I even make a device to know if I've got a patient that's going to respond or not respond, and at what position they're going to respond. So that is, this would be a screening or a records appointment where we're testing to find where this patient needs to be to have a successful outcome. What it does for me in practice is, number one, in a screening appointment, it shows them what I call their daytime area, the green line here. So if we look at this top graph from left to right, that's distance. And if we go from the bottom to the top, that would be the size. So the higher up that line is, the larger the airway is. Now, in between the two blue lines, those are anatomic landmarks. So the first one's at 8 centimeters into the mouth. And the second blue line to the right is at 20 centimeters down to the airway. So think of it as the back of the mouth or the beginning of the throat, all the way down to the Adam's apple. Now the green line is higher up, so that means it's larger. That's when the patient's breathing. We want to stop that instrumentation during this test at 50% of an exhale. So you have to watch the patient. I see everybody always watching the screen, and it kind of bothers me. It's like, well, how do you know what's going on with the patient? How do you know how you're holding the instrument? Because if it changes position, sometimes it's kind of like changing the x-ray head or the sensor when you're taking an x-ray. It'll look different. So we want to try to have apples to apples in all of these tests as we're going through. It's also why we want to repeat them at future visits. We don't just pull up an old appointment and use that measurement, because the patient will have different situation going on that day. It'll maybe in a different operatory, a different chair, maybe having seasonal allergies. So we just want to get everything comparable for the day. The bottom one in this graph is the rhinometry. And so those two blue lines are also distance measurements. First one's at 0. So I got to take a sip real quick. So that's where the tip touches the nose. The second blue line is at 6 centimeters. So that's about the exit of the nostril, the nasal passage before we get to the combined pharynx with the mouth and the nose. The 3 clusters or groups of lines, excuse me, are anatomic landmarks. The first one's the nasal valve. So if, like in this case, the yellow line is right on that big white line in the middle, that's the anatomic norm. These were data points found by the sleep team at Harvard Medical University, Atul Malhotra, and others. So these were the normals in their patient population, and there was over 1,000 people in this study. And so in this case, the yellow line is going to be their right, the purple line is their left. So their left nasal passages are just slightly larger than the right in this case, and they don't really crisscross. When you see the lines crisscross, then that's a deviation in the septum. If you do have cone beam technology, my advice is to mark at what distance that is, go into your data volume, and just confirm them. You can use Eccovision to really quickly get a quick analysis, and then if you've got a more detailed picture in 3D, this will pinpoint you to where you're not spending a large amount of time looking through your CBCT data volume. So just a little tip and trick. Nasal cycling is real. So you could take a rhinometry measurement and take it 30, 60, 90 minutes later, and it could be completely opposite, because the way we're designed as human beings is our left side will shut down and the right side will operate more predominantly. And then it switches about every 90 minutes. And so you get a reduction in the system demand of 1/2 of the nasal passages every hour and a half or so. So that will constantly change. If you have the technology, you always see the next two graphs are before and after decongestion. So if you were having seasonal allergies, if you thought it was soft tissue inflammation, you can give a decongestant, remeasure the left and right sides after the decongestant's done its thing, and then compare the left before and after, right before and after. And then you know if you're dealing with soft tissue inflammation. That's super important. So if you just have seasonal allergies, or maybe this is a child that has pets in the room, where I see rhinometry being utilized more and more are our airway health advocates. So they're trying to orthodontically expand cases and build that ideal dimensions. I like that approach. I'm a believer in it. But I also think we need to realize that even if we had an anatomically normal face, we can still have a collapsible airway. So the other thing that I see as I go into these practices that have been trained in these techniques is that the measurements for rhinometry, while they were normal in the patient population measured at Harvard, when I look at some of these kids that are getting expanded into ideal anthropologic measurements, their airways are much larger. They've got much larger jaws. They're capable of supporting all 32 adult teeth, and they don't need extractions. They don't need wisdom teeth removal. So they're very much more in tune with nasal breathing. They've got the myofunctional exercises going on, tongue's in the right spot. And if you're at all into this rabbit hole of airway health, nasal breathing is objective number one. We want tongue to the roof of the mouth, which forces air to go through the nose. We want teeth apart, so we're not in a clench. Muscles get relaxed, and then we will produce nitric oxide, which is your body's best anti-inflammatory out there. So the two instruments, Rhinometer and Pharyngometer, collectively are on the piece of equipment that we just call and refer to as Eccovision. So think of it like sonar, or sound waves going into these airway passages and then pinging back, and the microphones are listening. That brings up another thing that I run into quite a bit is we'll get a calibration, noise limit exceeds calibration error. So the patient grunts, the patient responds to a question if you're talking to them. So you've got to watch kind of what you're saying and your technique to avoid some of these time wasters, is what I call it. So the machine will go out of calibration, you take it out, you recalibrate it and take another measurement, and you're back in the game, which is a minor nuisance, but I like us to be super, super fast, especially if it's a screening appointment, because screening appointments, in my opinion, should be complimentary. We want zero obstacles for this patient to get into therapy, to get the care that they need and that they deserve. And so if we're identifying a high-risk patient, we want to be able to do a complimentary airway screening in 10 or 15 minutes. The goal of that is to get them into sleep testing. Not going to dive too deep into it on this webinar, but we have launched a new program to where that diagnostic testing is handled outside of your practice now. So if you're in here and you're an existing client, reach out to your representative from Sleep Group Solutions. We'd be happy to talk to you about some of the new services that are being offered out there and potentially get you signed up for that. So I know right before we went on there, we were talking about a future webinar for that. So hopefully it will happen in the next few weeks. And I know that will draw a big audience. So this picture here shows the airway metrics jig. Now from Dr. Doucette, he calls them Legos, and I kind of like it. It stuck with me because although I've never dropped one on the floor, stepped on it and hurt my foot like a Lego, I always kind of giggle when I go into practices that have the airway metrics kit, but they're missing one jig. Rebecca and I joke about it all the time. It's always the 8mm vertical edge jig that's missing, which is probably our most popular one that gets used the most. But we lose these jigs a couple ways. You send them to the lab never sends it back. You have an assistant that's not quite trained in sleep, and so it gets pitched or thrown away, or it gets left in the bite fork and sent off to the lab. So ways not to lose your airway metrics jigs right there. But basically what we're going to do here is put the patient's front teeth on top of each other, upper and lower arch in an edge-to-edge position, measure different vertical openings. So again, I don't use the 4 very often unless the patient has limited tolerance for how much they can open. So this would be someone that's in a more of an acute TMD situation. There I might use a 4. But the reason the George gauge was made at a 5mm bite fork is back in the old days, all of our appliances were made out of traditional acrylic, and you needed 2.5mm of thickness per arch. Thus, when you add 2.5 for the upper and 2.5 for the lower, that totaled 5. So while George gauge was sold with a 2mm bite fork, they just kind of all sat in everybody's closet because we never used them. It was not enough clearance for the materials of the day. Now we've got materials that can be much thinner. We have printed materials, nylons. We've got pressed materials and bioacryls and just normal tray type material. And we still have traditional acrylics. And who knows what we'll have tomorrow. There's so much fascinating stuff in the industry that's coming to market. But for most cases, we're going to find the patients are going to be in a therapeutic vertical at 6, 8, or 10. My 12s tended to be 4 bicuspid extraction. So that's just another pearl of being on the webinar tonight, is if you know you've got a patient that's had all 4 bicuspids extracted, you may want to go 6, 8, 10, and 12 just for giggles to see which one it is. Now in the study that's coming up, this paper right here, Doctors Jerry Hu, my friend out in Alaska, who's also now in Vegas, and John Comisi down in South Carolina, they did a simultaneous study where they made this patients, so it was the same subset of patients, and I believe there was 26 patients that went all the way through the study, where they had a device made using Eccovision, and they had a device made the traditional George gauge method. What they found was, in the George gauge, patients were allowed to go through the whole titration protocol, where you make it, you advance it until the patient says they feel better, then you would retest. With the Eccovision ones, they did no titration. And what they ended up finding is that when the vertical is respected and you put them in their ideal vertical position, oftentimes the edge to edge was all that was needed, and patient was able to tolerate it on night 1. So you didn't need to advance them. But when they made a set vertical of 5mm and brought them forward using just that 70% method that's taught by a lot of the labs, and then titrated even further, because you can't back any of those devices up very much, you want to set that vertical first and then come forward, because you can, if you do that, then you've got both dimensions in your wheelhouse. Otherwise, you're going back to the lab for another fabrication. And when that happens, you get another lab fee, which then comes back to cutting into profitability. But in their Eccovision bites, those patients were 5mm less protruded because we had respect for vertical than the ones that vertical was kind of disrespected, and everybody was given the same size, just like in that shoe example, and then brought forward until the airway opened up. Now, patients will have multiple spots where they can respond. Some patients will have no spots where they respond. And so that's valuable information that we get from Eccovision at a screening appointment or a records appointment, is just knowing what you're getting into. I don't think it's in this slide deck, but when I teach it, I make dental sleep medicine as easy as 3, 2, 1. So if we're taking that baseline airway measurement, the green line on the screening visit, you look at the mean on the green line. So mean green, just like the old football player. And if it's around 3, that's good. When we look at the red line and you look at the minimum, if it drops below 2, then you've got a high risk patient, someone that needs a sleep study. And then wherever that minimal collapse goes to, if we can improve it with jaw repositioning by 1 square centimeter, then we know we've got a really good chance, like 90% chance of having successful outcome with the oral appliance when we're in that position. Doesn't mean we're going to start right there, but it means that when we get there, we can expect a really good outcome. So it's having the ability to test your device before you get the lab fee to manufacture a device. When I talk to the labs, most of them will all agree with me on this, that cases that are sent in with a pharyngometer bite, they tend to not break unless the dog eats it or is dropped or there's damage. They don't break because the patient was wearing it. And my philosophy here is, it goes back to my patient Jim that I was talking about earlier. He had broken every silent night that I'd made for him, but he didn't break the tap and he loved it. And he actually said he felt better in that device. But he was probably someone that was a sleep apneic that I didn't have a diagnosis for, and we made him a snore guard because that's what we did back in the day. But when we correctly treated him, he didn't break his device anymore, and it lasted. Oh, gee, he found me in retirement, so it had probably been over 12 years when he finally called me. He says, "Where are you at? I'll come to you." And I said, "Well, Joe, I'm not practicing clinically anymore. I'm teaching dentists how to do this." So I was able to hook him up with someone in his area. So that was nice. So this leads into why I wear the cowboy hat. So I live in Colorado, so that's one of the things. But I really have been doing this for a long time, and we did a lot of guessing. Fortunately, we helped a lot of people along the way. I would say some dentists are scared to get into sleep because they're afraid of messing something up. But you have to really question yourself and think about, well, choosing to do nothing is not helping that patient either, and it is putting them in harm's way. So hopefully John and Cindy are still out there. I'm going to open up the chat window here, see what else came in while I was talking there. So I see names of people. At this time, we can open up to questions that might be out there. I'm not seeing questions in the chat window.
Yeah, I'm gonna wait to see if anything pops in, and I'll have Faustina check Facebook shortly. And if you want to go to the next slide for a moment, I
Yeah.
want to
Mine
see
closed out there.
here.
Did yours close out? Let me get out of there. Let me jump back to mine. So what's coming up? So I know this weekend I head down to Atlanta.
Yeah.
So we've got Dr. Blum is talking down there. We've got a great group lined up for Atlanta. We're getting close to the holidays, so this is always, it's a demanding time of year for all of your time, but it also seems to be also a busy time of year. The following week, I'll be doing a 1-day course in St. Louis, and that's with our partners at Dynaflex that are going to sponsor our event. But who I would like to see there is people that have been trying sleep one way or another and running into challenges, because in 2 days we can't cover A to Z unless we move really fast. And if you're new to this and you show up there, it's going to probably blow you away what we're capable of. But all are welcome. I know I've got a former classmate who's coming. I just saw one of my former classmates signed up who's in the St. Louis area, and I've got the entire residency program of where I did my residency coming, along with my attending doctor. And so that'll be fun. But he's been trying to get sleep going in the hospital for a long time. It's kind of a unique situation. It's a private practice, even though he's in the hospital or the doctor's building. So that'll be fun to talk to them, mainly because the new model that John's going to talk about in a few weeks solves a lot of the hurdles that are out there. So there's the teaser for that. As we roll into December, we're going to be down in Dallas, and then kicking off 2024, I believe I'll be out in Washington, D.C., and then we've got San Jose, Houston, and Chicago coming up. So
Yeah.
3 new messages.
We've got some questions here. So we'll start with the Q&A in the question section here. So we have someone asking for advice on how to like advice on getting consistent pharyngometer results, and any advice you have on coaching the patient.
So on coaching the patient, and Cindy, you've got a fantastic video about it online. So number one, when a client calls me, I always say, call Cindy. No, I say call Cindy's team. They'll hook you up with the link for the video, because I think a lot of our clients forget about the portal, or they don't know how to log into the portal. But there's so much valuable information in there, and we all want the easy button. And so, like, I don't mind people reaching out, but we really need to utilize all the resources we have. But how I would coach the patient is I would sit them in the exact same posture. I would hold the instrumentation in the same orientation. I would have them posture their tongue in the same place. So you never want to say the T word when you're working on a patient, because as soon as you do, it's always going to be in your way. But we've all know those patients where the tongue just shoots up into the back of the throat and closes off the airway. So if that happens, your Eccovision is not going to get past it. So they need to keep it low and forward. When we are doing our baseline test, we've got the mouthpiece that has the tongue depressor on it, so it's easy. But when we yank that off and we start using our airway metrics jigs, we have to use the jig as the tongue depressor. So my instruction to the patient there is I want you to put your tongue low and touch the back of your bottom front teeth, and use that jig as kind of your measuring stick to make sure you've got your tongue low and out of the way so the sound waves can get through and get past. Other coaching techniques is you got to watch the rhythm of their breathing. You've got to watch their tidal volume, their inhale, their exhale pattern, because everyone will have a timing to it. My younger daughter's a surfer, and so she'll sit out in the water and she'll watch the waves and she'll count the patterns as they come in. And that's kind of the analogy that I use here. John always laughs because I'm like the king of analogies. But you don't see that typically on the computer screen, and everybody wants to look at the screen. I look at the patient. I think about one of the pediatric instructors I had in school. If you put sunglasses on the pediatric patient, he would automatically fail you because you couldn't read the kid's eyes. You couldn't see if they were in distress. So watch the patient, watch them breathe in and out. If their rate is super high, so someone's breathing 18, 19, 20 plus times per minute, they're going to have a very shallow tidal volume, and you need to coach them to kind of, okay, breathe a little bit deeper, blow off a little bit more. But people that have very collapsible airways tend to have a very high respiratory rate. So you'll see them breathing 18, 19, 20 times per minute. So first you want to drop them down into that, 14, 15 breaths per minute. And then you want to be able to count in your head when they're at the top and then when they're all the way out, and make sure you get that baseline right in the middle of the exhale. Oftentimes, and Cindy, I know you deal with this on a daily basis, where the collapse test is higher than the baseline test, and that should never happen. Something weird happened. The patient did something different. The technique was wrong. Baseline, the green line, always needs to be higher, and the collapse test, while it can be similar, should always be lower. So if your collapse test is higher than your baseline, that means you probably stopped at the bottom of an exhale, and then you stopped your collapse way early because either the patient got tired and couldn't blow off anymore and just said, I'm done, just stop the test, or you captured it at the wrong place. So those are probably the two most common ones. The other thing that I like to do is I don't like taking it out of the mouth, because I think it's like taking the x-ray sensor out of the mouth. If you take an x-ray sensor out after you took an endo film and you try to put it back in later and take it again, it's always different. They're both accurate, but they're taken from different angles. And so of course they're going to look different. So if you can take a baseline and a collapse in one handling of the instrument and not taking it out, you're most likely to get the peak that's left of all the blue lines. So that's the oral cavity. If that peak is overlapping, then we know we've got the same instrumentation in the same position. If it does change, I don't get too upset about it, because typically it's the tongue, the patient swallowed, the tongue postured differently, and it changes the line. But where my focus is on those, the two lines in between the blue ones. When that's what we can control with oral appliance. So those are the biggest ones I can think of. And Cindy, I know you coach people every day. Did I leave off any of the major ones?
No, you did really good. And for I see a lot of the clients that are currently in here. I could send out my how to spot patient errors video. Again, that seems to help a lot of folks. Okay, so I have another question here. more of a request asking, can you review again the indication for non-responders?
So I don't like the term non-responder, number one, and I learned this one from Dr. Kent Smith, is even though you can't see the ideal improvement of 1 square centimeter and larger than 2, it's not a reason not to make a device, because if you've done enough cases, they're the outliers, but they're out there. Probably because the patient couldn't perform the maneuvers that you were asking of them in the testing, but you do the best you can with the instruments that you have at your disposal. If you can't see that 1 centimeter of improvement, do not label that patient non-responder. You know, do the best you can, still make the device, and I bet more times than not, you'll get subjective improvement. And then lo and behold, when you take the efficacy test, you'll see an objective improvement, and you're going to question, like, well, what's going on here? But again, I believe those fall into the patient's ability to perform the maneuvers that we're asking of them. So don't label people non-responders. What it does is it kind of gives you insight into how difficult the case is going to be. Sure, we would love to put everybody in therapeutic position on night 1 and call it done. But the truth of the matter is that's not going to happen. If we get the vertical right, and then we start bringing them forward and we measure. So here's another application of Eccovision, is use it when you deliver your device. Use it when you're following up on the device. Use it every step of the way. I think a lot of offices get so dialed into the training of screening and then finding the bite record that they forget to use it for delivery of device, and they forget to use it for follow-up. The other thing we have to keep in mind is delivering a device is just the beginning of therapy. It's not completion. So it's not like delivering a crown or an implant or a denture that you put it in and you're done. When you give someone an oral appliance for managing their sleep apnea, you're building a business inside of your existing business. And eventually, if it grows large enough, this becomes an exit and transition strategy to where when your eyes start to go, your hands start to shake, your back gives out, you can't work the days and hours, or you just get tired of the grind, pardon the pun. There's a future career. And I see it probably a couple times every month where I'm talking to a dentist and he's just like, this is such a blessing. You know, I thought I was going to have to sell the practice and give up. And now I've got new enjoyment for my profession. I've got more income than I've ever had into the profession. And I found an associate that can come and take over the practice. And it sets them up for a really beautiful transition where you can introduce the patient to your new dentist. You're still in the building. I'm kind of doing the politician thing is what I say. You know, you shake the hands and kiss the babies, but you don't have to do the hard work. You get to do the fun work. And the beautiful thing about sleep is a lot of it can be auxiliary driven. I would say one of the limiters that I see in a lot of practices are the micromanagers, the dentist that wants to get in there and do everything, which is fine if that's your style. It just doesn't have to be that way. I would rather be the maestro of Kent Smith, stand at a desk and orchestrate, 99 employees in 5 different locations. And just count the jingle when we go.
All right, I have another request here. Someone is asking if you could repeat the numbers when you look at the pharyngometer as far as the mean and minimum. I think
Okay,
they were referring to that awesome 3, 2, 1.
Yeah,
I love
it's
that.
really advanced here. I took it from NASA, but 3, 2, 1, like let's roll. Sleep. 3, 2, 1. The mean green line should be 3. So it's technically 2.8 for females and 3.2 for men. So I think we'd both all agree that 3 is right in the middle, right?
Yeah.
And then the collapse, the number is 1.86 for the minimal cross-sectional area on the collapse test, the red line. So again, it's 2. And then whatever that number is, so say they collapse down to 0.6. If you can get a jaw repositioning titration to measure 1.6, then that's probably going to be a successful outcome. If their collapse was 1.2 and you get them to 2.2 or larger, or in some cases you recreate the green line in your jaw repositioning, those are slam dunks. Those are the easiest cases. You can usually go there night 1. They usually don't need any adjustments or titrations. And so sleep can be as easy as 3, 2, 1.
All right. And then we have Someone mentioning they had a patient that was referred by a sleep physician, very happy with the Somnamid appliance, not snoring anymore. Husband is super happy and is asking advice if they should do a home sleep test after the few months to see their results or do pharyngometer again in a few months. And I think the answer is yes to both.
Yes to both. So number one, if they came in with an existing device and they're happy with it, my first tidbit of advice is never move someone to a different device, even if it's not your preferred device. Every time I've changed a patient from something that I thought would work better, they hated it and they wanted their old device back. So tip number one.
Doctor made it. Doctor made the appliance. They made it clear. So they're the ones that did the appliance. Yep.
Doctor made the appliance. So again, if patient's reporting subjective improvement. So the first thing I do when I deliver a device is I typically won't see them back in the practice for about 1 month, but my team is going to be calling them after night 1. If everything was good, they'll call them in a week. If things weren't good, they'll call them after night 2. And we just kind of coach them over the phone with how to do it. But we want to keep a diary or a log of their progress. And I will tell them, ideally you're going to wear this all night, every night, but I'm a realist too. So if you don't, that's okay. I just want you to write it down because in a month, you're never going to remember. If you've never worn anything in your mouth, it may take a period of adjustment for you getting used to this. If they've done Invisalign, if they've done tooth whitening, if they've worn a night guard, these are much easier cases because the patient's used to having something in their mouth. The next thing, if they've not done any of those things, is did you ever play an athletic sport where you wore a mouth guard? That would be my typical question. So once they're wearing it all night, every night, and there's no discomfort with the device, that's kind of where I start my timeline. So I'll go 6 to 8 weeks after that happens to allow inflammation to come down before I want to do an efficacy sleep test. If there's any trouble with the device and they're not reporting subjective improvement, that's when I'll use pharyngometer and I'll see, did the lab make the device where in the same situation that we had predicted in the jigs. Oftentimes labs can change things on you and not tell it. So there's a little checkbox on the lab slip that you need to make sure is filled in to use the construction bite, and don't let them guess because sometimes they like to do that. But again, that's getting less and less.
Awesome. Let's take a look here. Dr. Cusack, I got you. I'm gonna send you all the videos that I have that we have here. Okay, and I don't see any questions from Facebook.
If we missed anybody's questions, I'm just going to back up one slide if I can get my machine to do it here, and it doesn't want to. I was going to put my number back up.
Yeah,
but
scrolling through here, we got everyone, and yeah, we got the 321, we got the information. Yeah, we got everybody here. The last question regarding the follow-up and so forth, they're saying thank you. But no, it looks like we have all the questions here, and I don't see anything on Facebook. So if you want to verbally give your phone number again, I know that your email, jharrison@sleepgroupsolutions.com. I'm Acevedo@sleepgroupsolutions.com, although most of the clients have my info everywhere. But if you want to give your phone number out again, that way in case they want to reach you with any additional questions or inquiries, they can.
And I would really invite everyone, if you're not connected with me on social media, connect with me on social media, Facebook, LinkedIn. I do go to Instagram, but you'll find me in there. It's usually ZZZCBY, so Sleep Cowboy, or Laser Dentist, so LAZRDDS was my old handle. But you'll see what we're up to there. My email is my first initial last name, so it's the letter J, last name's Harrison, HARRISON, and this is always fun, Sleep Group Solutions with an S at the end, .com. You can call Sleep Group Solutions customer service line and they can reach out and put you in touch with me. My mobile number is 719-648-9982. And if I've worked with you as a client, I send out a lot of articles and things that come across my desk. If you're not one of my clients and you want that stuff, shoot me an email, shoot me a text, say, yeah, please send me articles. I send out maybe one a week or so just to keep people in touch. The last one was pretty interesting. It had to do with, are the metrics changing? So, you know, there's a movement for AHI not being the metric that we measure severity of disease. And this came up in a recent sleep conference where in 5 years, do you suspect we'll still be using AHI as the metric, or will it be something different? And so there was one on ventilatory burden. It's hard to say, but it's close to hypoxic burden, which was the topic of one of the conferences. So it'll be interesting. I think another webinar that we should probably start to look at is remote patient monitoring. So, you know, classically, we've done these follow-up sleep studies, but there are becoming more and more advances in wearable technology to where we can get self-reporting to a cloud-based platform on a daily basis that comes directly from the patient's device back to our office, whether it be a ring or something that's implanted into the device that's being researched and tested. I think that's gonna be a hot topic in the next year or two. So remote patient monitoring, or RPM, is what's coming down the pipe. Well, I thought it was gonna be a short webinar, but look at that, we're right at
I know,
7 o'clock my time, but 9 o'clock on the East Coast.
Come tomorrow, once we're back in the office, we're going to be working on CEs. We're going to send everyone some information. If anybody wants a copy of tonight's video, we'll have that link available tomorrow, but this is always going to be available on our social media channel on Facebook. So feel free to watch it again, or feel free to share it with somebody who might benefit from it. That would be really, really great. Again, Dr. Harrison, thank you so much for your information.
Of course.
John, I don't know if he's somewhere in the background. Thank you for that as well. And guys, if you guys have any questions whatsoever, please feel free to reach out to us. Those of you who are existing clients, I'm going to reach out to you guys personally, send you some videos and some information. And as usual, thank you so much for joining Sleep TV tonight.
Yeah, breathe well, sleep well,
Good
live
night,
well.
everybody.
Good
Thank
night,
you,
everybody.
guys.
Thanks. Bye-bye.